So at IMS 2024, I had the opportunity to provide an overview of the landscape of chimeric antigen receptor T-cell therapies in the relapsed multiple myeloma setting. I was able to review some of the data for the late line approvals, such as data from the original pivotal KarMMa study as well as CARTITUDE study, which showed that for patients with at least 3 prior lines of therapy and triple class exposure, in fact, many of the patients being triple class refractory, chimeric antigen receptor T-cell therapies targeting B-cell maturation antigen have truly revolutionized the field. We have seen progression-free survival of 8.8 to 35 months using the 2 different products that are currently FDA approved, which is ide-captogene viclucil as well as cilta-captogene autolucil. And this has really been a remarkable improvement from PFS that was under 5 months previously for these patients. So I think that led to their approval, FDA approval in March of 2021 for ide-cel, as well as February of 2022 for cilta-cel. And in the last year, we have seen the data for anti-BCMA CAR T cells in earlier lines of disease in the KarMMa-3 trial, wherein ide-captogene viclucil was studied in patients with 2 to 4 prior lines of therapy with significant improvement of standard therapies with a median progression-free survival that was 14 versus 4 months for patients with triple class exposed disease. And this was really a very impressive landmark for these patients. As well as we have seen the use of cilta-captogene autolucil in early lines of therapy in the CARTITUDE-4 trial, wherein we saw almost a 74% risk of progression or death with the use of cilta-captogene autolucil in earlier lines of disease when compared with standard of care daratumumab, pomalidomide, and dexamethasone, and pomalidomide, Velcade, and dexamethasone. And in fact, at this Congress, we saw an improvement in overall survival that now favored cilta-captogene autolucil. So we're seeing that BCMA-directed CAR T cells are really revolutionizing the field of relapsed myeloma. Earlier this year, the FDA approved both cilta-cel and ide-cel in early lines with slightly different FDA approvals in terms of their indications. However, we are routinely using these now in clinic. I think the next steps will be how we can incorporate these CAR T cells even earlier line, including newly diagnosed settings, as well as how can we improve the access, persistence, and availability of these CAR T cells for patients with relapsed disease. So those are some important areas of ongoing investigation. So CAR T cells therapy is a very important new treatment avenue for patients with relapsed myeloma. I think the most important factor that comes in is the fact that it has transformative efficacy, really hands down improving overall survival, progression-free survival compared to standard approaches as early as second-line myeloma, as well as late-line multiple myeloma. So first of all, is its transformative efficacy. Additionally, CAR T cells are typically a one-and-done type therapy where patients go through this procedure and then are followed with active surveillance. So this has in numerous studies shown improvement in quality of life over ongoing standard treatment options. And patients really enjoy the treatment break as well as improvement in quality of life that comes with these therapies. So I would say that for both of those reasons, this frequently is a preferred strategy for deep, durable remissions without additional therapies, which is what our patients need. Of course, it's not without toxicities, and there are some unique toxicities, but I think we are developing a better understanding of how to identify, mitigate, and treat some of these toxicities. I think that autologous stem cell transplant is a modality in treatment of myeloma that has long been a strategy that has mostly benefited patients who are fit. I think with the advent of CAR T, with better development of patient selection strategies, as well as mitigation and treatment of some of the toxicities, this has become accessible to more patients who were traditionally not candidates for autologous stem cell transplant. I think the very frail may still be excluded in most efforts, but overall, I think our T cells has the ability to reach far more number of patients in terms of their eligibility than autologous stem cell transplant. One of the greatest bottleneck, though, remains in terms of access to these therapies, because much like autologous stem cell transplant, these are mostly available at larger transplant programs. However, I do feel that significantly higher number of patients will now be CAR eligible that may or may not previously has been autologous transplant eligible. So I do think that with right patient selection, this can be carefully offered to select number of frail patients. So there are several unique challenges that I think need better understanding. We are doing much better with our understanding and treatment of cytokine release syndrome, with high-grade cytokine release syndrome and immune effector cell associated neurotoxicity affecting first of all, a small number of patients, and then we're developing better treatment approaches, early identification for these things. However, the areas where we continue to struggle remain ongoing delayed cytopenias. We continue to struggle additionally with on-target off-tumor toxicities as well as delayed neurotoxicities, which I think we understand poorly. Additionally, treatment options for these delayed neurotoxicities are largely unsuccessful, and patients continue to deal with certain types of neurotoxicity events for a prolonged period of time, which deeply impacts their quality of life. Luckily, with movement of these therapies into earlier lines, with better bridging strategies, with better education about identification and mitigation of some of these toxicities, we are doing better. But I think there's still a lot that we don't understand. The other aspect that I think will need further study is the risk of secondary malignancies, in particular hematologic toxicities. For the longest time, it has been felt that many of the patients who receive CAR T cells have been very heavily pretreated with prior autologous stem cell transplants, but this risk seems very real, as high as up to 10% of the patients in some of the original studies. I think as these therapies move into early lines, particularly newly diagnosed, where patients may or may not go to autologous transplant, I think those larger randomized studies will help us understand if there's a clear signal and if we can identify a patient phenotype or subset where this is more likely to happen, so we can select our patients much better.